What we're going to do now, unfortunately, like I said, Madison wasn't able to be with us tonight. So we're going to talk a little bit about the Digest Fees Scale, which is a new tool that was published in the past year. Um, in terms of disclosures, we received funding from the ASHA Foundation through their researcher clinician grant mechanism, and that's what funded the development of Digest Fees. For those of you who may not be familiar with what Digest is a scale known as the Dynamic Imaging Grade of Swallowing Toxicity. It was developed initially because there was a need for a tool specifically in head and neck cancer clinical trials. So we're seeing a lot of research being done comparing things like radiation therapy or chemoradiation therapy and something like a TORS or transoral robotic surgery. But we didn't have a good way to really compare the swallowing outcomes. And so that was sort of the reason why Digest was initially developed. The initial scale was developed for video fluoroscopy. And at the time that we started working on the video fluoroscopy version of Digest, we started having conversations about the need to adapt this for fees. And so that's what we're going to be talking about primarily tonight. The nice thing about Digest is that it provides a structured criteria that lets you rate the overall safety, the overall efficiency, and the overall impairment of a swallow. So it's not at a bolus level, it's not at a consistency level. It's when we look at this patient, how severe is their dysphagia? And so the benefits of Digest is that it does provide this sort of common nomenclature, things that we can talk about with our colleagues. We all know what it means if I say somebody has a safety grade of 3 and an efficiency grade of 1. We know that means this is more of a safety impairment versus an efficiency impairment. It also can sometimes help profile so that you can establish treatment recommendations based on if somebody is much more of a safety impairment, you may want to focus more on safety interventions versus efficiency interventions and vice versa. And then it is one of the few things that provides an overall severity score, again, across boluses and across consistencies. But it's really important to know that there are limitations of Digest as well. So Digest is not meant to give us information about the underlying physiology. We have other tools that can give us that information, like the MBS-IMP, for example. It does not measure oral dysphagia. It is purely looking at the pharyngeal phase of swallow function. So in someone where there are considerable oral phase considerations, we need to think about something else to rate those. It doesn't provide information about timing or coordination. It does not consider the impact of compensation. So it's looking at the uncompensated swallow severity. And at this stage is predominantly validated in head and neck cancer. However, there have been some recent publications or presentations, I should say, not published yet, looking at this in a number of different populations as well, such as Parkinson's and ALS. So I think we're going to see additional validation in other clinical populations in the near future. So as I mentioned earlier, when we started working on the validation of Digest scale, Dr. Hutchison and I talked about trying to validate this for fees. And so we decided that we wanted to bring in a group of clinical and research experts who had experience both in head and neck cancer and fees. So you can see the team of people who converged on Stanford a couple of years back to work on the original scale development. So you can see Dr. Susan Langmore and Joe Murray, Joe Patterson and Justin Rowe from the UK, Lania Risi, Jess Pisegna was not able to join us physically at Stanford, and then Kate Hutchison and myself. And so what we did to establish the scale was we had this expert consensus panel. We had 8 individuals with greater than 10 years experience working with both fees and head and neck cancer patients. And we did what's called a modified Delphi approach to establish consensus. So we rated together 24 fees examinations. What we would do is we would watch the video, everybody would rate what they thought the Digest safety, efficiency, and overall grade severity was. Then we'd review the results in a de-identified manner, discuss where there might have been some differences of opinion, and then did a second round of voting based on that. And what we found was that we had quite good agreement on that second round of voting, more than 90%. We can see the strongest degree of agreement was for the safety scale, which is what we would have anticipated and have seen in subsequent studies, which we'll talk about. So this is what the safety grading looks like. And for those who are familiar with the digest scale, the digest fee scale is the same as the version 2 version of fluoroscopy digest. So what it's doing is it's looking at the penetration aspiration scores, and it's looking for the worst penetration aspiration scale score over time, and then looking at how frequently that happens and how severe those events are. So for example, we can see if we go down here to PAS of 7 or 8, a single event that is not gross is considered grade 1 impairment. We're not worried about something that happens once and is trace. But when we get up into where it's intermittent, we go up to a grade 2. Or if we get into a point where we're looking at either chronic or gross amounts of aspiration, those are going to go up in grade as well. So it's got this structured criteria for what these different things are. So intermittent is less than 50% of bolus trials, whereas chronic is 50% or on more than one bolus type. So that's how the safety grading works. The key things when you're using the safety rating, first is that we rate the worst penetration aspiration scores of all swallows of a single bolus trial. So if somebody swallows 4 times to get a bolus down, we look at the worst PAS of those 4 attempts. So it's going to be a little bit different with the safety and the efficiency. We don't want to double count penetration or aspiration events that are happening from something that was from a prior bolus trial. So if I take a drink and I aspirate and there's still some stuff in my piriform sinuses, and then I aspirate that same material again, we don't count that as 2 events of aspiration. We count that as from 1 bolus. Once there's a cue or a compensation, so cough, clear your throat, tuck your chin, we stop rating. So it's only rating the uncompensated swallows. And so again, we look at the worst penetration aspiration scale score across trials and the frequency of occurrence. When we went to adapt for fees, the bigger challenge became the efficiency piece. Penetration aspiration scale scores have been shown multiple times to be relatively equivalent between fees and modified barium swallows. But there's a bigger challenge when we're looking with fees because we can't see what proportion of the bolus has entered the esophagus. And so this is where we had to do a lot of our discussion and a lot of our adaptation. So we looked to some of the existing residue scales. There's the BRAC scale, which was initially designed by Dr. Langmore's team, and then the Yale Pharyngeal Residue Severity Scale, both of which have pros and cons to them. So we wanted to think a little bit more about how do we optimize this. And so another sort of more recent look at how do you rate residue reliably in fees came out of Jess Pisegna's lab. And what they looked at was they looked at how if a clinician were to say this is moderate residue, and then you looked at sort of the percentage of residue is there, it took much less residue with thin liquids to be considered severe than it did with puree or solid foods. So we knew that we had to think a little bit about this from a consistency perspective, because when we see residue of thin liquids in the pharynx, we think of that as being more severe than when we see a similar amount of material that's of a thicker consistency. One of the other things that Dr. Pisegna's work has shown is that the more specific you are in asking a clinician how to rate it, the more unreliable those ratings get. And so what she has found is asking a very broad question like, how much residue do you see, was the most reliable way of rating residue. And so we sort of came up with a efficiency grading system taking all of those things into consideration. So we looked at sort of minimal to no residue being less than 10%, somewhere between 10% and 33% residue being a mild degree of impairment, and then moderate is up to about 66%, and then greater than 66%. But then again, we have to take into consideration the different bolus types that are being presented. So you can see that if we're seeing majority residue with liquid or pudding, that's going to be considered a higher grade than if we only see that with a solid bolus. And then the most severe residue is looking at, does it happen with every single consistency or just some of the consistencies? And so here are just some examples of different grades of what we might see on a fees exam. So on this exam, you can certainly see there are little bits of blue in the pharyngeal recesses, but less than 10% residue certainly, so that would be a grade 0. Here we can see there's a little bit more sort of pooling, just a little bit more in the molecular space. We can't see the piriforms particularly well, but we're probably up towards more 10% in terms of residue. We can see here in this grade 2, again, we're increasing. We can see more of the molecular recess filled as well as the lateral channel. And then we have the two different mechanisms of getting to grade 3. So this would be 34 to 66% of puree. So again, looking at the molecular space being about half full, as well as some within the laryngeal vestibule here, versus grade 3, where we can see more than 66% of the bolus remaining. This is particularly impaired individual in some, but maybe not all of the trials. So there's a couple of key things for doing the efficiency rating with digest fees. The first one is that you want to estimate the residue based on the initial swallow. So if somebody spontaneously swallows 3 times to clear the residue from the pharynx, you want to just look at that first time, because we want to see what can they do on the first swallow, because normally we don't need to swallow 3, 4, 5 times to clear something. So we're just looking at their initial swallow. But anybody who's done many fees knows that there are times when you can't see a thing after that first swallow. Either the scope is coded or they're swallowing 3 times in a row. So in those cases where you can't make a judge after the first swallow, you make it as soon as you're able to visualize the pharynx. Again, it was sort of an approximation. This is the part that's hard for most people to sort of wrap their heads around. Is we're not saying it's a percentage of the bolus. We're not saying it's a percentage of the pharyngeal space. We're just saying what percent residue. So it sort of takes into consideration both of those things, how much bolus went in, as well as how much space there is. So just to give you an example of like when you would want to rate the residue, I'll just play a quick bit of this so we can see the bolus coming through, and that's where we want to rate, not after more material has come through, not after that second swallow. Okay, so once the scale was established, we did reliability and validity testing. We had 3 experienced speech-language pathologists who met rating criteria, and then they independently rated 100 FEES exams to establish both inter and intra-rater reliability. We did a 30 exam repeat for each of the raters. And what we found is that we had quite good reliability, both inter and intra-rater reliability. As we expected, the efficiency was slightly lower in terms of reliability, but still these numbers were actually quite comparable to the reliability findings for digest fluoro. So even though the scale was adapted, even though we're using it with a different tool, with very similar reliability rates. In terms of looking at from a validity perspective, we had a number of different measures that we looked at. One was the MD Anderson dysphagia inventory, a patient-reported outcome measure. We looked at functional oral intake scores, so a measure of swallowing, diet levels. We looked at secretion severity scores, and then we looked at using the Yale pharyngeal residue scale, both for the vallecula and the piriform sinuses. And we can see that we had quite nice validity across all of these measures. So in terms of future directions, we are in the process of developing a formal training protocol. This will be, as some of you know, one of the first digest training online things happened today. We will be wrapping digest fees into this at a future time. Again, looking at validating digest fees in a number of different populations. Other than head and neck, there's already some work being done in, again, Parkinson's and ALS. And then around the same time that we started working on the digest fees, James Curtis and James Borders and the group out of Columbia had started working on the VACES methodology of rating fees exams. And so we're actually doing some collaboration to see, is there a way for us to integrate some of the VACES methodology into how we do digest to further increase the reliability for residue ratings?